So what does a typical cervical traction for a herniated disc? Do you know any of the mechanisms with which it is promoting the healing process? Like, are we adding a negative pressure within the disc? I've heard these things. Are we influencing fluid flow? Are we influencing cytokines? Are we influencing nerve fiber behavior? Like, tell me more about those mechanisms.
Yeah, so you hit the nail on the head overall. So I mean, if we think about our intervertebral disc, it's 1/3 of our body height for our entire spine. So the beauty of it is, if I'm going to sit there and I'm going to do a little bit of traction and I'm going to open up and separate that space, I'm going to decrease that overall intervertebral pressure at the disc itself, which is one of the most important things that we can do. And by doing that, you're going to increase the amount of cytokines in that area. It's going to create a neuropeptide, and it's going to decrease the pain. So if you look at general, if we separate back pain into two, or upper, let's say neck pain, we separate cervical pain into two different things. Two of the biggest mechanisms are mechanical based and chemical based. The beauty of traction is it's going to treat both of those. Mechanical issues are, i.e., I have a forward head posture, I sit too much in flexion, so being able to traction, that's going to separate the vertebrae. And from a chemical standpoint, it's going to treat that inflammatory aspect as well. So typical treatment protocols that we prefer to use here at Pathway Wellness are, we like people to come in 3 times a week and just do straight traction. Now, we do that on top of some exercises and some other things like manipulation, but the traction itself, majority of protocols call for a minimum of 3 times per week.
Interesting. And so we've do you actually see, how do I word this? I don't know if they've done pre and post MRI studies. Do you see actual physical structural changes in the disc, or do you just see functional changes in pain and how the disc functions?
Functional changes.
Yeah, that's what I was thinking.
Decrease in radiation symptoms, stuff like that. You're not going to see an overall change in the amount of like degenerative change that the disc itself. Um,
Yeah,
that's just not going to happen. Your annulus, if you had a disc protrusion or herniation or anything like that, and that disc slowly started leaking through that annulus, it might decrease that pressure enough so that annulus can kind of that disc, the nucleus can sneak its way back in and take pressure off that annulus. And you might see changes there. I don't think they've done any studies, but I don't think you would see actual decreases of any form of degenerative changes.
Yeah, I remember talking about structural changes and things like that. I remember in school, one of the pieces of information I saw is that those structural changes actually can happen, but you're looking at like 18 to 24 months before. And I always told patients, like, we're going to let the body do what the body's going to do in 18 to 24 months of treating this. And that won't be in office. That would be you treating it, right? A little bit more exercise, a little bit more better habits, a little bit better nutrition. And then in the interim, my goal was to get you out of pain as quick as we could so that those structural changes could happen within your body in a more pain-free state, in a better confident state, so that you weren't always worried about reoccurrence of pain, and let the body do what the body is designed to do. Let's give it all the tools we can. And then over the next 18 to 24 months, those discs will heal themselves and maybe we can get you out of pain in 3 months. And so then you're not dealing with disc pain for 18 to 24 months. Um,
Yeah.
so is traction only good for those discs? Is it does it attack other aspects of neck pain like osteoarthritic pain, facet
Yeah.
pain, or
Yeah, so I mean, if we think about the majority of mechanisms of neck pain, injury wise, I mean, majority of spinal root irritation, disc irritation, facet changes, osteophytic changes. At the end of the day, all those are decompressing the area. They all go back to that, no matter what. If we have DJD, extrinsic muscular spasms, facet joint pain, all of that, being able to slowly, intermittently distract those joints, you're going to reset that area. And traction's an interesting one, man. I mean, the first time that I was ever exposed to it was at one of my rotations. They did what was called chiropractic biophysics. You ever hear that?
I can't say I would be able to identify that as a modality specifically.
Which is just straight traction protocols.
Oh, interesting.
So they start somebody out. Yeah, so they start somebody out with like a Denerol. And then they would go into a traction machine where they'd have somebody pull you forward. They'd have one on the thoracic spine pulling you forward, and then one on your low back as well. And I was so confused, and I was like, "What is all of this?" But like even with all that stuff, like patients still got better. So being able to take the minimal aspects of that, of being able just the decompression side is the most important side. But,
Yeah, and I remember in school, I always told people this traction was such an old technique. It had been around forever. It was an inexpensive modality, easily applied. But the big thing when I was in school was there was a marketing company that tried to make these big fancy machines, and it was like $150,000 machine. It came with this marketing package, and they called it intervertebral disc decompression. And I was like, oh, so it's a traction machine? Like I can get one on Amazon for $20, and you could do it yourself. And so now, and the thing that always struck me about these companies, and as a doctor, you need to be a good up to date on research, but you also need to be a good consumer of the marketing industry that's targeting you, because everybody was signed up for a 20 plus traction treatment package, right? It didn't matter if you had mild pain, awful pain, everyone got 20 treatments out of the gate. You prepaid or you went on a monthly payment. And whenever I heard that, I was just like, ooh, that's a little bit weird. So I was like, what if I get better at 6 treatments? Or what if I get better at 8 treatments? Or what if I need 40 treatments, right? Maybe it's not even 20, maybe it's 40. And that was the big thing for me, was they repackaged that traction modality. And so is there an ideal treatment timeline, or does it depend on the patient? Does it depend on the severity of the injury? Like, how does that equate to treatment modality length of time?
yeah, so that's going to be patient dependent. I mean, as majority of things are. The biggest thing with that though is that it's going to be severity is going to dictate it to a certain degree. But if you when all the screens just started changing, it threw me off.
That's right. That's right. Yeah, I think he was going to bring up a picture of maybe the traction units. Yeah, it looks like he had something
Me
there
and
to show
Jason
us.
got a little bit more.
Yeah. Oh wow, look at that one. That one's
So that's chiropractic biophysics right there. So we used to set.
uh
So we would set patients up on this. So chiropractic biophysics, the way that we would run it was somebody would come in and you would do your initial examination. That would include an X-ray, where then it would go and be compared to a normal, quote unquote, normal spine, and the normal
mhm.
would have these beautiful, perfect green lines, and then yours would have these red lines, and you'd be like, "Holy shit, I'm dying." So you would end up doing minimum. Our minimum treatment plan was 42 visits.
Woo.
A lot of
Wow.
visits, right?
That's a lot of
So
visits. Yeah.
you would come in the first 3 treatments, 3 to 5 were on a Denerol, which if you don't know what a Denerol is, we actually have them here at Pathway. They're actually really good. They don't restore your cervical lordosis, that natural curve of your spine, but it helps decrease pain so you can kind of put it in its normal position that it wants to be. So essentially, if you look at the picture, the poster, the one in the back, the cable that's pulling up, is trying to pull them into a hyperextension, really.
It looks like it's going vertical and extension, and they got one pulling in the opposite direction, pulling into like a
Yes,
mid cervical
it's
spine.
trying to drive that lordotic curve.
Uh,
Pretty. I've been set up in them before, and
is it intense?
it's intense. You feel
It
a
looks a
lot.
little claustrophobic.
And then if you do some of the clinics are, our clinic actually did them. They did full spine X-rays, which the
I never
research
understood.
the research and validity of doing a full spine X-ray, I mean, is pretty poor, anyways. But
Okay, good. Because I was gonna say, I always what I learned of X-rays, when I see a full spine X-ray, I'm like, the tops and bottoms are so distorted. The central rays coming in, and it at a couple of vertebral height away from it, you got no valid image. And then if you're doing a full spine, you're trying to get C1 down to L1 5 S1. Like I can't do anything with this thing, right? And they were trying to find spinal curvatures. Is that right? And trying to
yeah,
induce like yeah, that was a big thing when I was going through school, is getting back to that normal cervical curvature. And I remember the research showing that even if you were able to restore it to some degree, there was no correlation between pain relief and or function. Is that correct?
correct. Yeah, and man, I
Yeah.
was an intern, and I was hooking somebody's neck up in one way, being pulled forward, their thoracic spine, their low back, and I'd be like, "Does this hurt?" They'd be like, "Yeah." And I'm like, "All right, 5 minutes."
Does it hurt?
So
All right, well, suck it up.
we'd set the timer, and I'd be like, "Oh God, this looks terrible."
I imagine though a certain percentage get
I got
better, right?
70%.
Because
Yeah,
yeah, because you're still inducing some motion in the spine, and whether that it kind of lends itself to sometimes there is this like I think all modalities, while based in some logical thought process, produce some level of positive change, right? You're
Oh,
getting
God, yeah,
hands
man.
on, a positive influence with a doctor. They tell you they know what's going on. They tell you this is going to help you. You're getting some mechanical motion in the spine, which is what a lot of people are lacking. And so you get benefit. And that's one of the hard things as a doctor is trying to be retrospective and looking at your treatment paradigms and making sure you're understanding what's actually happening. It can be a difficult. So I think no matter the modality with a hands-on treatment, you're going to get some benefit because there is some
It makes it.
inherent benefit to natural hands-on treatments.
Yeah, I mean, I think the biggest thing that showed us that was ultrasound, right? I mean, ultrasound, they did so many. Ultrasound was one of the first, maybe diathermy, but ultrasound was one of the first that I saw in research that just showed how doing sham studies, unplugging the machine and doing the same exact thing got the same result.
Yeah.
You just spending 5 to 7 minutes of having a conversation with the patient while rubbing an ultrasound machine on them, they'd be like, "Yo, my God, my tennis elbow just went away."
Yeah. It's
And
wild, huh?
it's crazy. It really is.
Makes you wonder
Placebo
as a physician.
is a beautiful thing.
Yeah, placebo's great. And I think it's gotten a bad name.
Yep.
Um, I think it is not a negative. It's like if I could harness that, and even some of the new studies that we tell you this is a placebo, we tell you this is a sugar pill, we tell you this is whatever, and it still helps. Like you're just
Yeah.
trying to harness the brain's own ability to heal itself. And I think we're in the very early stages of understanding that. And I think in 50 years, we hopefully we're shocked at what level of capacity for healing we have naturally inherent in our own bodies.
Yeah, I would agree with that. And when I went through school, one of the big terms was, and this is a good thing, they just started throwing out there was nocebo,
Hmm.
which is just, it's weird, but it's just how like words matter in a clinic. Like, like being, how looking at a patient and telling them you have degenerative disc disease, you have degenerative joint disease. Like these words, like they sit home with patients. So just sitting there and telling somebody that they're degenerative, you just lost all function. Clinics, and the beautiful thing about what we do here at Pathway is we treat function, not pain. Eliminating pain to a certain degree, it should not be that hard. You should be able to put somebody in a proper position in 4 to 6 visits, and you should be able to decrease the overall pain. But after that 4 to 6 visits, treating the function is what's going to make sure that keeps them healthy long term.
Yeah, I agree. I think that was probably, if I look back and I'm honest, that was one of the mistakes I made as a young chiropractor and a young clinician. Is I really wanted to get my treatment. I wore it as a badge of honor. How low could I get my treatment plans?
Yeah,
And that 4 to 6 was like my sweet spot. I wanted to get you out of pain. I wanted to try my best to educate you, but I saw my job as reducing your pain. When in reality, now that I'm a little bit older and I'm sort of seeing life through a different lens, I'm almost like I think I may have done a disservice by not teaching those patients how better periodic preventative care over the long haul will reap significant rewards later on down the road. And now having seen that for
yeah,
myself, like I one of the examples I use, the easiest one is I get a massage every 2 weeks. I don't care if I'm hurting. I don't care if I feel great. I don't care if there's a problem. I don't care if there's not a problem. I just go every single twice a month, no matter what. And I'm starting to view some of the modalities in chiropractic that maybe I did a slight disservice. I'm thinking that maybe that monthly chiropractic visit probably would have had a significant cumulative effect for my patients in the long run had I truly understood the positive nature that that could have given them in the long haul.
yeah. And I think wellness care as a whole gets bashed, and I think maybe the term of it is a reason why, like overall wellness care, but restorative and performance care is just getting treated one time
I
one
like
time.
that. Say that again. Say that again. Restorative and performance care.
Yeah, just be yeah.
Oh,
So
that's
restorative
good.
same thing as like a overall wellness care. You should be treating your body more often. Period. And I think in society we're pushing more into that direction. But so like this podcast, we're talking about cervical traction. It's a beautiful, beautiful modality. It decreases interstitial pressure, takes pressure off osteophytic joints. It's going to help restore degenerative changes, take pressure off that nerve. It's going to help a lot of things, but then you got to reinforce that kind of stuff. So it's everything is it's a long journey. It can't be like a 1 to 4 treatment thing. And it's taken me a long time to realize this too. I was similar, and have less experience treating patients than you, but I was like, I love being that guy. Oh, call me, come in, I'll take your pain away, and then I won't
Hmm.
see you again. and I loved that at first. But then I would see them in 6 weeks, and I did a poor job explaining it earlier. But it's kind of like, the pulling the scab example. But it's, you have the same. Everyone comes back. Hey, the right side of my neck hurts. You treat it, they get better. 8 weeks later, hey, the right side of my neck hurts. It's always the same thing over and over again, because you're just diminishing that pain for that moment, but you're not actually changing anything. So it's
Yeah, I
yeah,
like that restorative and performance care. I think as a chiropractor, I don't want to say blame, but I'm going to say that maybe the origin of that thought process came from schooling. And I went to chiropractic school not knowing anything about chiropractic, and I was always taught that wellness care side of things was about changing the placement of the bone, changing the shifting of the spinous process, and you had to do over time. And I think that's what I was pushing against. And since that was coupled with the idea of wellness and preventative care, it made no sense. But I was throwing the baby out with the bathwater, and maybe the explanation was the bad part, but maybe the wellness care was actually the good part, right? And so having
yeah,
now in my later 40s, I'm like, yes, restorative and perform. I like that term. I'm going to start using that. And for myself, that's what I do is like, I don't go to massage therapists because my shoulders are tight or, hey, my traps are this or my low back or my, oh God, there's trigger points there. It's just like, no, it's restorative and performance. And I just know that overall I feel better with a hands-on treatment of massage therapy. And I also think one of the negative sides of chiropractic is it was always just, at least in my experience in my school, it was all spinal manipulation. It had to be spinal manipulation. And I never as a chiropractor needed that mode as a patient, sorry, I needed that modality personally a lot. It was great when it was great. For me, it was always occiput adjustments. Man, they were like a godsend, life-saving
there's always
treatment
that one,
modality.
right? Yeah,
Right, but other than that, I was like, spinal manipulation didn't do great for me, and so I don't know why I need to get manipulated all the time. But if it was if it was maybe better explained to me from a more comprehensive approach, right? Spinal manipulation, manual trigger point work, cervical traction, restorative exercises that are going to keep the tissue moving better and healing better. If there is an injurious state that is brought on, you're going to perform much better. I think I would have been able to buy into that explanation a little bit more.
yeah, I agree with you. I mean,
And
we
you're
went through.
also seeing this in traditional, sorry to cut you off. You're also seeing this in traditional medical now is like, we used to wait until you had an injury. We used to wait until your testosterone got to 200 and you had erectile dysfunction and you had muscle loss. And we used to wait until, you had this serious immune function. We used to wait. Now it's like, hey, what can I do with stem cells to prevent injury? What can I do with exercise as medicine to prevent injury? What can I do with my peptides to be better functioning? We were just having this discussion the other day of like one of our patients who was in his 60s, and I was like, my God, the man's looking amazing. Like, I want to
Yeah,
be I want to be him when I'm 65 because he's crushing it. He just looks good. Skin looks good. Muscles look good. He's been working out. He's been doing hyperbaric, been doing peptides, been doing testosterone, just like crushing it. And I was like, that I think you hit a nail on the head. I'm going to steal that from you. That restorative and performance is so much better explanation of what's happening when we do these sort of treatments in a proactive wellness approach for sure.
yeah, it's interesting what you do when you start treating the person and not just the symptoms, right? And I think that was like
Yes. Amen.
we're kind of going back into that. We're doing a whole 360. Traditional Chinese medicine. They were, like my favorite example was somebody comes in for a gastric or a peptic ulcer. They just doesn't matter. They give them this medication, it takes it away, but they didn't take away any stress, any diet changes, no nutritional, no lifestyle changes. Just take the medication, ulcer is going to go away. Year later, same thing happens again. You see it with diverticulitis. You see it with gout. People are like, I'll just get that one episode per year. So going back and just treating the symptomology, just treating the person as who they are and the things that come up. That's the beauty of it.
Yeah, I think that's true. Treating the person, not just the injury. One last thing, as we're getting a little short on time, but I wanted to talk to you about like, do you couple and do you find better results if you couple, as I'm thinking about this, like maybe cervical traction with manual manipulation, cervical traction with manual therapy for musculoskeletal issues, or do you find that it's too much, or do you like to keep it as a pure traction visit? Or tell me what that looks like in your office.
So in our office, we typically try to run three traction protocols a week, where they come in, say Monday, Wednesday, Friday. On two of the visits, though, they're seeing a therapist at that time. So in my opinion, it should be coupled with something. Not everyone
Therapist as a massage therapist, or
there's just, or you as a chiropractor as a whole.
Okay.
So
Okay.
like, I'll see them, not necessarily having to be a hands-on manipulation, but also looking at thoracic spine, going over McKenzie stuff, and manipulation. I'm a big fan of cervical manipulation. I think it's very helpful. I don't think it always needs to be that grade 5. You can sit in that grade 3 to 4 range and just do mobilizations like mulligan stuff. But it does a good job increasing that range of motion at that joint to allow storing function. And I don't think, like we move joints, not bones, right? So like joints being able to alter that kind of perspective and get that neurological response, like there is benefits to that.
Yeah. Now I want to go down the road with you and think you had a physical therapy background, correct?
Yeah.
And then went to Cairo. Do you think your thoughts of cervical manipulation are influenced by the physical therapy's approach to cervical manipulation?
Yeah, 100%.
Because
So I
in my experience with physical therapists taking classes with them or doing CEUs with them or practicing with them, is they were always a little nervous of cervical manipulation, grade 5, that last cavitation. Whereas Kairos, we were just taught like that's just what you do, right? And so I always found it interesting that they were nervous of that last little
Yeah,
part of the manipulation.
I agree with you. I was very lucky that when I went through PTA school, I had an amazing physical therapist, Jim, and he's the one who told me to go to Cairo school over physical therapy school.
Oh wow.
He was the main guy who told me, "Hey, listen," he was a great mentor. And I think you'll see it now, and if you study if you look at a lot of the research and stuff like that. And this is a hard comment, so we'll see. But
Wade
I,
into it, brother. Go the
I think
controversy.
I think one of the biggest issues with physical therapy as a whole, and now this new movement of severely evidence-based chiropractic, is that the research isn't where it needs to be, so no one's trying anything different. So we're just doing the same, and I agree with exercise. We've gotten way too fancy with Instagram and TikTok and shit like that. That we need to dumb it down, keep it simple. Stupid is effective, but we're not doing any of that kind of stuff anymore. We're getting too pushed into the nuances of care. So like,
Yeah, so did I hear you say that maybe doing strictly research-based care is not producing the results that it was intended to because the research is not up to par enough to influence our care, so we're just doing the exact same things over and over because the research is just repeating the
yeah,
same exact paradigm. Yeah, I would
yeah,
agree. And I always tell people evidence-based care is not research-based care. Evidence-based care is 1/3 research, 1/3 patient preference, 1/3 doctor's experience. That's
correct.
where those all three intersect is where evidence-based care intersects. But I think a lot of people have bastardized or confused or misunderstood that evidence-based care means what does the research say? All research is done by humans. Humans are emotionally, intellectually, to a certain degree, subconsciously or consciously flawed. And so all research is going to be tilted with a certain lens. So you have to take it for what it's worth, but you also have to honor the patient's perspective. And you
Yes,
also have to honor your practical experience with those patients. That's why you're a doctor. If if the if the patient could just look up a research article and say, "Oh, this is what I should do," it's going to work, then it cuts out the need for us as physicians. But if we don't bring anything to the table, i.e., our practical experience, then you're almost pointless. But if you also don't rely on the research, then you become Wade and doing the same thing over and over.
yeah. It's a hard balance. But like what you just said is that's like the biggest problem I had with the whole biopsychosocial model right now. It's how patients should be treated, but we're removing that bio aspect of it. It's just becoming a psychosocial model. That biological aspect of it, you need to treat the human with, they have certain pain derivatives. You're controlled by hormones and nerves and inflammatory responses. So if you don't treat the biological aspect of it, doing traction, doing ART, doing Graston, whatever your cup of tea is, you're not treating the patient. You're just treating the psychological aspects of it. So
You're
that's why
making the same mistake that the physical people did, but just in the opposite direction.
just in the opposite direction. So like we're losing that care as a whole.
Yeah, I don't think I've ever heard anybody articulate that well. That was interesting how you said like when you try to do research heavy or research based practice, it's not going to give you the necessary outcomes because the research is not where it needs to be, and so you're basing it on a sole treatment paradigm that maybe is not as up to date as it should be, or is not as effective as it should be. And that's an interesting perspective. I think it really articulates well what sometimes the problem you see uh, with practitioners who either don't have enough practical experience, aren't good at practical experience, or aren't. Here's the other thing I see is sometimes as a practitioner, you don't do a good job of understanding your patients. You don't do a good job of coalescing that practical experience that you've learned over the years to then change how you approach. If you approach a patient day one the same way you approach a patient day 100, 200, day 1000, if you approach them the same, you have missed the boat completely. It should be
Yeah,
influenced by like, patient one responded this way, I tweaked it a little. Patient 10 responded this way, and over, and you subtly shift, and you just become better as a practitioner. But if you're always just saying, "Well, the research says this," then you're never going to
right, right.
change. Yeah,
And
that's interesting.
it really is hard to find that middle ground too, right? Like you either get in the habit of being that Cairo who just flying sevens everyone to put stim and heat on them, adjusting out the door, or you're like, I need to do hour-long treatments and I need to correct every single little movement. But the biggest thing that I've learned in the last decade of treating patients is I do way too much every visit. Like
Yeah, it's tough
it,
to kind of find that fine line, right?
yeah, I used to kitchen sink approach everything. Whether it was I wanted to do Mackenzie, then I wanted to throw in a little DNS, and then do some cupping and ART, and then I was like, well, I don't know what the hell worked.
Right. Yeah.
I know they feel better,
Yeah.
but
I sometimes leave that as a personal approach. I leave that with the patient. Like, do you have a desire to know it weren't like I'm going to use these treatment modalities, and here's my approach. Do you have a preference of knowing what works, or should I throw the kitchen sink at you to get you better?
yeah,
But to allude to your previous point, I think sometimes that happens to physicians when we practice in on an island, right? Whether you're in a multidisciplinary practice or not, but you don't interact with the other practitioners. So one of the things I've appreciated of working here with you guys is like, I'll come at from a nurse practitioner point of view and a chiropractic, right? You come at it from this point of view. Dr. Bledsoe comes at it from this point of view, and we're able to, and we have such intermingling of us as physicians and the patient that we can sort of challenge each other, think new thoughts. And so it's been beneficial for me as maybe an older practitioner compared to you to get your point of view, and I sometimes hope it's beneficial for you as a younger chiropractor to see my point of view. And so I
yes,
think that's one of the benefits, but it's also tough for a physician because a lot of our self-worth is wrapped up in our ego, and it's hard to accept sometimes like, maybe I wasn't doing that the best, let me change a little bit and take
right,
their
right.
input or take their practice. And so that's been a big benefit for me as a practitioner, both chiropractic and nurse practitioner, to have other people's points of view. And I think that's one of the advantages of our setup here at Pathway Wellness.
Yeah, we're a multidisciplinary practice, and that's the best way to practice, in my opinion. I mean, the one thing we can all agree on is neck pain. It's increased 21% in the last decade. Interventions need to change. Of course, we're going to do more research. We're going to figure out more things. But where we're sitting at right now is doing cervical traction coupled with exercise and myofascial release is the best way to treat it, as well
Yep.
as adjusting the neck. But
Yep.
it's yeah,
And I agree. And then also, throwing in some as a nurse practitioner. If I leaned only on that side, like I have medication modalities, I have trigger point injections, but I really like to do those when they're coupled with manual therapy in the office. I know it's being done. I know it's being
yeah,
done by good practitioners. We're going to do trigger points and we're going to do cervical traction. Not like, oh, I'll do these trigger points and go see your chiropractor. It's like, no, we do them in the same visit, or we couple them together. We see which one gives you better benefit. Like those trigger points didn't seem to do a whole lot. Let's lean more into the
yeah.
traction. Or those trigger points seem to really help you. Let's lean a little bit more into those. And so that's been nice too, is to really add those different modalities, which tend to live in separate practices. We've been able to combine those in the same practice.
Yeah, you've been a blessing with it. I mean, sometimes it really is hard to treat that pain, right? If you can't get that inflammation out of the way, then it's really bad because then the function of the patient's going to get worse in those next couple of weeks. So sometimes we tend to lean away from doing things like cortisone shots and trigger points outside of our practice. But it's shown me being here with you. It's a great intervention to add in if you really need to speed up that pain process, decrease that pain process to increase function, to then allow us to do things like traction so the patient's not in pain the entire time, and to do things like soft tissue and etc.
100%. Yeah, I that was one of the driving forces that led me to taking an advanced practice degree. Was like I just started seeing more and more patients who as a chiropractor in school, I was told wouldn't happen. I can treat everybody, no matter their musculoskeletal condition or no matter their condition.
Yeah,
But what I found in reality, that was not true. And I had patients who I couldn't even touch. They were so scared or they hurt so bad, and I would refer them for a Toradol and a cortisone shot. I would refer them for some simple. You got to do this first and then come back. And that was one of the driving forces that led me to do that. But what happens, I think, is you live on these islands where you've got medication, so everybody gets medication. That's the only thing you do, right? And then you've only got an adjustment, so everybody gets adjusted. But maybe using, instead of like this giant carpet bomb of adjustments or medication for every patient, it's like a little bit of adjustment, a little bit of
yeah,
medication, same patient, different patients. You can tweak and make it much more appropriate for that individual patient.
I agree. I agree. It's been a blessing to learn that kind of stuff from you.
All
And I
right,
was
Doc.
super anti it
I,
at
I,
first.
what's that?
I said it's just interesting how fast things change in correlation.
Fast.
Yeah,
Well,
things
Doc,
happen.
it's been great talking to you. Before I let you go, I want to touch on one last subject. There's been some rumors floating around about your ski erg ability,
Yeah,
and I wanted to just clarify for the folks out there. So, as a younger person, one would think that your performance would be better than the people in the gym who are older than you, but that hasn't necessarily shown to be true, right?
not to put my head down, but yes, that is very true. Some people like to work better in that 75-85% range, so 95% above. But yeah, no, you whipped my ass on it, man.
Yeah, oh man, prevail. I'd love nothing more in my life than when I could beat a younger person at athletic event. Now I
I,
know that
I know you needed that, so I gave you that.
I
I just,
appreciate you throwing me that bone.
just so everyone knows, this happened on Saturday, and today is Friday.
I'm still
So
talking about it.
I had to hear about it every single day. And he went in the gym today, and he increased the time, so now I have to go work even harder.
Well, listen, my wins as an ever aging male, like my wins are getting lower and lower. Like my daughter's breathing down my neck in CrossFit. She's already passed me in like 6 out of 10 things. My wife's better than me at things. I'm like, this is like I've got to take my wins when I can get them, and whenever I
Skier
could beat
might
a,
be your thing.
I might just become a specialist. I might become a skier. I don't know, specialist. Maybe I'll just be that
Break that
person.
record, baby.
All right, Doc. I appreciate your time. It was good talking to you, man.
All right, it was a pleasure. Thanks.
All right. Have a good one.